Clostridium. Clostridium are anaerobic obligatory gram-positive spore-bearing bacilli. They are motile except Clostridium perfringens and Clostridium tetani type 4. Clostridium perfringens and tetani are found normally in intestine. Spores can be spherical and terminal, uh, which gives a drumstick appearance, example in Clostridium tetani. Oval and terminal, which gives appearance of tennis racket, example in Clostridium difficile. Others include central or subterminal spores, which is found in botulism and Clostridium perfringens. They are non-capsulated except Clostridium perfringens and Clostridium vitricum. Coming to Clostridium tetani. Clostridium tetani, which is the causative agent of tetanus in culture. So there is swarming. Alpha hemolysis is produced, which later develops into beta hemolysis. It is a strict anaerobe. Tetanus toxin consists of tetanolysine and tetanospasmin. Tetanolysine is oxygen labile and has no role in tetanus. Tetanospasmin is oxygen stable plasma coated single chain zinc metalloprotease released in wound with low redox potential, cleaved into heavy chain and light chain. Heavy chain mediates the binding and entry of light chain into nerve cell. Light chain enters the axon and is transported to nerve cell body in the brain stem spinal cord by retrograde intraneural transport. It doesn't cross the blood-brain barrier. It blocks the cleavage of synaptobrevin, protein essential for function of synaptic apparatus. It presynaptically blocks the release of glycine and GABA inhibitory amino acids, which decreased inhibition resting firing state of alpha motor neuron and causes rigidity. The thing to note is that strychnine acts postsynaptically. Clinical manifestation of tetanus. It is little invasive property. In incubation, median time of onset after injury is 7 days. Most common form is generalized tetanus, in which toxin enters the lymphatic and blood stream. First symptom is increase in tone in masseter muscles called trismus or lockjaw, followed by sequential involvement of nerves of head, trunk, extremities, descending tetanus, since short nerves are affected earlier. Hands and feet are relatively spared. Mentation is unimpaired. Deep tendon reflexes increase. Autonomic dysfunction, sympathetic increase. Sudden cardiac death may occur. Short incubation period associated with grave prognosis. Neonatal tetanus usually occurs as generalized form. Diagnosis is always clinical, since microscope is unreliable because it can be isolated from wounds without tetanus and can't be isolated from wounds with tetanus. Treatment. Antitoxin is best to give before wound manipulation. Human tetanus immunoglobulin is the preparation of choice. Decreases mortality. Management of wound is as follows. If the wound presents within 6 hours, clean, non-penetrating and with negligible tissue damage. Category A, B, C, D. Treatment. For category A, nothing more required. First, coming to the category. Category A, which has a complete course of toxoid within past 5 years. B, had a complete course more than 5 years but less than 10 years. C, had a course more than 10 years. And D, had not completed the course of tetanus toxoid. So the treatment for category A is nothing required. For B, 1 dose of toxoid. C, 1 dose of toxoid. And D, toxoid complete course required. For other wounds falling in category A, nothing more required. B, toxoid 1 dose is required. For C, toxoid 1 dose plus human tetanus immunoglobulin. And D, toxoid complete course and human tetanus immunoglobulin. Antibiotics like penicillin and metronidazole eradicate the source of toxin, alternative clindamycin or erythromycin, but have no role if given more than 6 hours. Prevention. It is best prevented by active immunization with monovalent vaccine, 2 doses of TT, first booster after 1 year, second dose, and second after 5 years of third dose. Combined vaccine, DPT. Passive immunization. Human tetanus hyperimmunoglobulin is the best prophylactic to use in terms of passive immunization. Combined active and passive immunization can also be given. Coming to Clostridium botulinum toxin. The botulinum toxin is the most potent bacterial toxin known. It produces 8 distinct toxins, of which all toxins except C2 are neurotoxins, while C2 is enterotoxic activity. It acts on the peripheral cholinergic nerve endings. CNS is not involved and it blocks the release of acetylcholine. Toxin A is used for treatment of strabismus, blepharospasm, cervical dystonia. Clinical features: foodborne botulinism is due to preformed toxin. Characteristic symmetrical descending paralysis occurs. Deep tendon reflexes decrease and it is associated with severe constipation. Death is due to respiratory failure. Wound botulinism. Toxin is produced in the wound. Infant botulinism. Source of infection is usually honey due to ingestion of subterminal spores. Toxin is produced inside the spores and it occurs in infants less than 6 months. Botulinum food poisoning doesn't cause diarrhea. Infant botulism, the most common form of botulism. Diagnosis by demonstration of organism or toxin, antitoxin in serum. Coming to Clostridium difficile associated diarrhea, the most common diagnosed diarrheal illness acquired in hospital which results from ingestion of spores, almost exclusively in association with antimicrobial such as clindamycin, ampicillin, cephalosporin. It releases toxin A, enterotoxin, and toxin B, cytotoxin. Both glycosylate the GTP binding proteins and disrupts cytoskeleton. So fluid is leaked, leading to whitish yellow plaque formation of a colon known as pseudomembranous colitis. Most common symptom of Clostridium difficile is diarrhea. Complication is toxic megacolon. Diagnosis: demonstration of toxin in the feces by its characteristic effect on hepatitis 2 and human diploid cell culture. This is the gold standard. Treatment of Clostridium difficile associated diarrhea is metronidazole. If not responding for more than 48 hours, then vancomycin is used. Clostridium perfringens is the causative agent of gas gangrene enteritis necroticans type C. Toxigenic as well as invasive. It is capsulated, non-motile and shows stormy fermentation. Absence of its subterminal central spore in artificial media or pathological tissue is the characteristic feature. It is the most common Clostridial species isolated from tissue infection and bacteremia. Clostridia are present in the normal colonic flora. It is the most abundant and is followed by Clostridium perfringens. Toxins. Clostridium perfringens produces 12 toxins. 4 major toxins are alpha, beta, epsilon and eta. Alpha toxin or phospholipid C or lecithinase is associated with gas gangrene. Alpha toxin is hemolytic, gives hot cold variety. It shows Nagler reaction in which there is a zone of opacity is formed where there is no antitoxin. Beta toxin has necrotizing properties. Theta toxin is antigenically related to streptolysin O. Clinical features: skin and soft tissue infection, includes gas gangrene, Clostridium myonecrosis, most commonly caused by Clostridium perfringens type A. Characteristic pathology: near absence of polymorphonuclear sites despite extensive tissue destruction. Incubation period is 10 to 48 hours with Clostridium perfringens. Diagnosis: frozen section biopsy of the muscle or gram staining, which shows gram-positive bacilli without spores, indicates Clostridium perfringens. Showing citron bodies and both or leaf-shaped pleomorphic bacilli if it is Clostridium septicum, and show large bacilli with oval or subterminal stores in case of Clostridium novae. Treatment is surgery. Drug of choice is clindamycin plus penicillin or hyperbaric oxygen. Intestinal disorders caused by Clostridium perfringens. Food poisoning. It induces calcium-dependent alteration in the permeability. Other intestinal disorders caused by Clostridium perfringens include enteritis necroticans or pig bell caused by beta toxin of type C strain. The gas gangrene producing spores are usually destroyed within 5 minutes by boiling, but those of food poisoning strains of type A and certain type C strains resist boiling for several hours. To the questions: botulinum toxin produces exotoxin, which differs from other exotoxin in that it is produced intracellularly and appears in the medium only on death autolysis of cell. The toxin production in botulinum is determined by bacteriophage. Most common type of botulinum is infant botulinism. Swarming growth is shown by gram-positive bacilli like Clostridium tetani and Bacillus cereus, and gram-negative bacilli like Proteus mirabilis and vulgaris. The characteristic feature of botulinum paralysis is it is symmetrical descending paralysis. There is absent fever, heart rate is normal or slow, patient may remain responsive, sensory deficits doesn't occur. All the anticholinergic features like diplopia, dysphagia, dysarthria, blurring of vision, diaphragm are seen.